Nobody better than Dr. Crandall and his team to kind of guide us through what the literature says and maybe also what their own experiences and tips and tricks are, when to use it and how to use it effectively. So take it from here, Maryland, and great to have you with us today.
Thanks a lot, Jens. It's great to be here. Thanks for having us and giving us this opportunity to share this information. So this is, let me share. I'll start my presentation. So basically, we're from the University of Maryland, from the neurosurgery department. These are our disclosures, which are not relevant to this talk. So I did my residency training at the University of Maryland, and then did a spine fellowship within the neurosurgery department at the University of Miami, and then I'm finishing my 5th year of practice at Maryland. My practice, I do a lot of spinal oncology as well as trauma and then another mix of degenerative and deformity, but I do a lot of intradural work, and I think that I've discovered the real importance of using intraoperative ultrasound for spine cases. And I'm joined by 2 of our superstars. Tim actually just graduated from residency just a few weeks ago, and he's moved to San Francisco and is about to start his spine fellowship at UCSF. And then Josh is one of our 5th year residents who's also going into spine surgery. But basically, I want to talk about intraoperative ultrasound and how it can be used as a tool to sort of give us a lot of information within spine surgery. And we're going to talk about that. And I'm just going to give a quick introduction before we discuss the journal articles. So we have 4 different papers, but I'm going to start with an introduction. And then if we have time at the end, I actually have another case a quick case to present of a recent patient that I had where I think that ultrasound was sort of pivotal. So this is just an example of an ultrasound, spinal ultrasound. It basically looks like an MRI, essentially. If you hold the probe in the longitudinal axis of the spine, it's almost the same as a sagittal view, where you have, this is the dorsal dura, this is the CSF dorsal to the cord, this is the spinal cord itself, and then this is the ventral dura, and this is a small disc herniation here that's touching the front surface of the cord. And then on the right side of the screen, this is essentially an axial image. You basically turn the ultrasound probe about 90 degrees, and you can see you can see the nerve roots on the side. It's actually even a more detailed view than what we're able to see, on an MRI scan. Sometimes you can see the denticulate ligaments. This is a little piece of arachnoid over here, and it can be really, really helpful. So the main benefits of it is that you can see through the dura and you can see through the spinal cord without opening it or without retracting it. It allows us to determine the extent of the pathology, be it intradural or ventral to the spinal cord before doing anything else. You can use it to confirm that you're at the appropriate level, because before you start doing certain things, obviously you have to do a laminectomy first, but then you can see, okay, the tumor is actually there, or the disc herniation causing spinal cord compression is actually at this level. And then you can ensure, once you're done with your surgery, that the spinal cord is decompressed. So for me, I use it for every case where there's intradural pathology. I find that it's very helpful when there's a tumor to make sure before I open the dura that I'm far enough above and below the tumor, because the last thing I want to do is have to drill more bone when there's when the tumor I use it for pretty much every thoracic case, primarily to ensure that the spinal cord is decompressed. Even if I'm performing just a laminectomy, I'll still use it to make sure that there's not a ventral disc herniation that's also causing stenosis. And then I also use it for some select cervical cases as well, when I want to ensure that there's a good decompression. One quick case, this is just to start things off, 74-year-old female with a pathologic fracture in this retropulsed bony fragment into the spinal canal, causing spinal cord compression. And And basically we performed a transpedicular decompression as well as posterior osteotomies. And you can see this is the ultrasound image before we did the decompression, showing the fairly significant compression of the spinal cord. And then after we did the decompression, as well as closed the posterior column osteotomies, you can see that the spinal cord is now decompressed. This is that same or very similar sagittal image that we just looked at. And this is a video that I'm going to play basically showing this. This is actually a different patient. I didn't have a vid, but it's almost the exact same case, showing this large bony fragment compressing the spinal cord. And you can see, normally you see spinal cord pulsate up and down. You can see the pulsations in the arachnoid above, but the spinal cord itself is very severely compressed and it's not really pulsating at all. And then this next image here, this is another video showing after we removed that big bony fragment, you can see that there's now CSF in front of the spinal cord. And if you look at the ultrasound video at that point, you can see how the spinal cord is pulsating. And then this is just another case, one last case before we get to the papers. This is a case of a patient that had an arachnoid web, which you can see, this is like looking at an ultrasound, you can see how there's this little indentation in the spinal cord. And on the MRI imaging, you could also see that there was some edema within the spinal cord as well at this level. But when you play the video, you can really see how the pulsations in the arachnoid and how the CSF cannot transmit past this area of the spinal cord really pummels the spinal cord at that level. It's almost like the spinal cord is getting punched with every beat of the heart. And this is why, this is a problem. And this is why these patients develop, these myelopathic symptoms over time. And this is an intraoperative photo of that same patient showing this fairly significant arachnoid adhesion here, which was preventing the CSF from flowing. And this is after we removed the arachnoid adhesions. So next, I'm going to turn it over to Josh, where he's going to discuss the first two papers, and then we'll come back to Tim, who will discuss the other two papers. So just give me 1 second to pull up Josh talk. All right. Go ahead, Josh. Tell me when you want to go to the next slide.
Sure. Thanks, Dr. Crandall. So good morning, everybody. So to start, we'll review a literature review on this topic, which was published earlier this year, actually, in Spine, with the goal of the paper the authors noted was really to review the current spine literature focusing around ultrasound in order to try and establish a definition of what decompression means. And you can advance the slide. So again, this is a systematic review. The way they did it was the way they do every review, where they went through several databases, including Medline, Embase, and the Cochrane Register. Again, with the goal of trying to establish a definition for adequate spinal cord decompression using intraoperative ultrasound. They included specific papers, studies that were using intraoperative ultrasound that were guiding surgical decompression at all spinal levels, cervical, thoracic, and lumbar. Specifically in cases that did not involve intradural work. They were looking at cases of degenerative disease, trauma, and extradural tumor cases. And they actually excluded intradural conditions. And then, of course, papers that were using other ultrasound modalities that were considered non-imaging or non-diagnostic modalities like Doppler, three-dimensional ultrasound, microvascular Doppler. And then excluded some studies, too, that were looking at ultrasound for guidance of doing anesthetic blocks. To assess the risk of bias in these papers, they use the QuadDOS tool and the Miners tools. Again, it's kind of standardized paper review tools. You can advance now. So the paper initially, they found a bunch of papers, almost 1,000 papers that had these, I guess, search terms, intraoperative ultrasound and spinal cord compression. But after filtering out several records for either duplicate or other exclusion reasons, they limited it down to about 31 papers. You can move on. where initially they kind of parceled out the way they were reviewing it and to start with an overall technique, which they found a theme of how everyone kind of does this, which is in the way that Dr. Crandall kind of described, which often is from doing some form of posterior decompression where they either do a laminotomy or laminectomy and removal of the ligamentum flavum to allow you to see the neural elements, and then fill the field with sterile saline, which allows you to provide acoustic coupling for the ultrasound. And then you place that ultrasound transducer in the saline above the cord or the neural elements that you're looking at, and that allows you to kind of provide the images that you see here on the slide. Then they looked at the different papers that were looking at specifically the different parts of the spinal cord that were being studied. They started with the cervical spine, which they noted that this was probably the most well-studied area in which intraoperative ultrasound is used. Again, with their initial goal of trying to define what the definition of decompression would be using intraoperative ultrasound. And they noted that across really all areas of spinal cord decompression, they were really noting that these are all qualitative definitions, implying that it's the way that it kind of looks, right? And you kind of know what it looks like when you see it. So the way that they define that is there's a few terms that they use. The idea of the spinal cord floating is what they would consider was considered a key theme of decompression, which you can see in the transverse view number 1 here on the slide. That's their kind of key idea of the idea of a decompressed cord or neural element. So again, they said adequate decompression was characterized by the ventral aspect, specifically of the spinal cord, free floating in CSF, and avoiding any contact from the anterior elements, either it be a disc or OPLL or whatever. If it was still compressed, they could say the severity of the compression was described by the resultant shape of the spinal cord. So again, qualitative in nature, how it looks on the imaging. In thoracic spine, this was also essentially the same kind of concept. They use very similar terms. Again, echo-free space or floating cord comes up. But in the thoracic cord, they noted a specific use that was important in several studies where specifically in trauma, the trauma applications in thoracic spine, when they were providing basically reduction of fractures, the fracture reduction was you could actually, during fracture reduction, you could see in the spinal canal as you're providing ligament ataxis and repositioning the fracture fragments, you're able to identify in real time that you're reducing that area and decompressing the spinal cord. Of both of these, in cervical spine and thoracic spine, they did note that while you can see this imaging study and you can provide that real-time decompression of the neural elements, many of these studies provided kind of mixed or inadequate data suggesting that there's any relationship to neurologic outcome afterward. There's kind of a mixed bag across all of the studies in the review. Some of them say, oh, sometimes patients get better, some don't, and then a lot of them don't comment on that because they're more focusing on their radiographic criteria. When looking at lumbar spine, this was actually the least studied area in intraoperative ultrasound, and the one I would posit may have the best area for improvement in that foray. But the thing that they did note, which was unique in lumbar spine, which obviously doesn't really apply in cervical and thoracic spine, is the unique use of ultrasound to look at nerve root decompression, which allows you to look at more lateral elements. The way they describe that, again, is qualitative, in that adequate decompression of the nerve root would show when the diameter of the nerve root really normalizes, and they can follow that with the ultrasound along the nerve root's course as it appears kind of smooth and decompressed. In the same way, this kind of floating concept. Finally, the last bullet I have here on the slide is this concept of pulsatility, which again, Dr. Crandall kind of touched on with the case. There were 5 studies they identified that measured pulsatility after decompression, with the notion that this may be a surrogate measure of some form of extrinsic compression of the cord within the subarachnoid space. And if you see pulsatility, it would imply that this should be sort of synchronous with an idea of decompression. But again, not all patients show pulsations, and there's no association in those studies that they found with any kind of clinical outcome. But again, the same kind of qualitative concept applies. You can advance the slide. So kind of summing up this review article, the review article actually provided a nice key points section in their paper, which again kind of sums up everything I sort of just said in the results. But to review, they felt that intraoperative ultrasound, and I would agree, is a useful tool in spine surgery for identifying decompression. In several cases, specifically the ones that they looked at here in their review were degenerative cases, trauma, and extradural tumors. And it's also specifically useful in thoracic spinal trauma cases, specifically burst fractures where we're trying to reduce the anterior element. And I would also posit probably lumbar cases as well. In the lumbar spine, it has a unique ability to show decompression in lateral structures, looking at exiting nerve roots. And again, their ultimate goal was to identify the definition of adequate decompression. And in this case, they're really, again, defining kind of a qualitative description, kind of how it looks in that CSF space. Based on all the papers, there's still insufficient evidence to suggest that using intraoperative ultrasound would give you any idea on how their clinical outcome will be later on. So overall, it's a good introductory review article. I think it highlights a lot of the points that we'll talk about further in this talk. And they were really able to identify a common definition qualitatively of decompression, essentially that free-floating concept, which I think is important to note. Again, it's a heterogeneous study to look at all a bunch of stuff in the review article. So limited inferences can be made on outcome or other things. But again, nice review of the overall points of intraoperative ultrasound.
All right, thanks, Josh. I guess we can go on to the next one.
One second.
Or do you want to talk about? Yeah.
So thank you for this, and this is a great way to start off with it. So I have a quantitative question, and that is, in this SR, if you kind of quantify the main applications, cervical, thoracic, lumbar, and then indications-wise, what was the distribution? And then the second question is anterior versus posterior. Is there any role in checking corpectomy qualities, for instance, for cervical and thoracics? Was that mentioned? Thanks.
Sure. So for this, I guess I can answer your second question first. There was mention of anterior decompression. The most common one they talked about was posterior, but there were a few papers that talked about specifically what you described, using ultrasound and anterior corpectomy to look at basically ventral decompression directly. But you should be able to get the same imaging quality as long as you have enough space for the ultrasound probe. The first question, as far as I'm sorry, can you repeat the first question?
Distribution, cervical, thoracic, lumbar, and indications.
Yeah, so the distributions, I guess, as far as the reason why they used the ultrasound, again, it was looking at, a lot of these were really radiographic studies that they showed it. But again, it was kind of looking at this technique to show decompression. But the indications across the board, they didn't use anything for intradural. I don't really know why they excluded that specifically, but that was, again, not the primary focus of their paper. They wanted to look at, I guess, extrinsic decompression, or compression rather than, and then the evidence of immediate decompression.
And since you used the R word, I have a follow-up question, the radiology word. Who does these in their review? Is this a surgeon-driven technology that's used, the modality, or is this radiologists who come into the OR and then run the ultrasound?
Yeah, so in a few, it kind of is varied. At least at our institution, it's really all driven by neurosurgeons. However, in the papers, it varied based on the way they describe the methods. So in some papers, just the neurosurgeons evaluating qualitatively what they saw intraoperatively. A few of them did actually have radiologists come in and kind of like independently review the imaging, but it's a little varied.
Thank you.
Sure.
Josh, I have a question. How large is the tip that actually measures that does the measuring?
Yeah, that's a good question. So if you've ever seen the different probes, do you want to answer this one, Dr. Crandall, or do you want me to?
Yeah, I can. I mean, I wish that I had pictures of all the different probes. That would have been a good thing to sort of give an example. So there's different sized probes, and they're typically much smaller than the ones that the anesthesiologist used to say put in lines. The two probes that are most commonly used. So first of all, you can actually use the same machine that the anesthesiologist used to put in lines. It's just that the probe's a little bit big, so sometimes you have difficulties fitting it. But I do that because at one of the satellite hospitals that I work at, they don't have the expensive intraoperative ultrasound machine that we have at the university. So I do use one of the other probes, and it works. You just have to try to get to fit in there. But and then it's also not a sterile probe, so you have to use one of those sterile sheets, and you have to fill the inside of the sheath with gel, and then you have to in all these cases you have to flood the field with saline in order to be able to transmit the ultrasound waves. But the two main probes that we have that most of the actual intraoperative ultrasound machines can accommodate or potentially even come with, there's a cranial probe, which works very well, and then there's this special probe that looks like a hockey stick, and that's the one that's more generally related to spine surgery and was more or less developed for spine surgery. But the actual end of the probe is probably about 2 centimeters or so in length, and it's shaped in a way where you can hold it and you can kind of put it into smaller areas. But to also answer Jens's question with regards to anterior, as Josh said, the biggest issue is being able to fit the probe into where you're working, which you should probably be able to probe into an anterior cervical approach. I don't think that you would get much information just a discectomy. I think it would have to be a corpectomy, and I think that it could certainly have good use in say the patient has posterior ligamentous buckling. You would be able to see, is there still some posterior compression of the spinal cord, or maybe when you distract open with your distraction pins, if that posterior buckling goes away. But I haven't tried it, so I'd be curious to see, with our probe, whether or not we're able to do that. The other idea that I had, which has to do with probe size, is I tried using one of our probes on a lumbar microdisc just to see if you could see if there was a residual disc fragment, after you removed the main disc fragment, and unfortunately I wasn't able to get the probe into my small microdisc incision with enough depth in order to see what was going on. But that was an idea that I had. They do sell very small probes that are made for pituitary surgery, but we don't have them at our institution. But I'd be curious to see if maybe even a probe like that you'd be able to stick into like an ACDF discectomy, or potentially even a microdisc like I was talking about.
Yeah, that would be great if they have that, because that's the question, how much decompression do you have to do? Did you do enough? Do you have to take more?
Yeah, for sure. All right, we can move on to the next paper.
Sure. So the next paper kind of leads into that nicely. We're going to go back in time a little bit to the early 90s. Look at a publication that actually came out of shock trauma with Dr. Geisler, that looked at the use of intraoperative ultrasound in 30 patients that they followed prospectively that underwent surgery for cervical spinal cord injury. So the goal of this paper was to basically determine the use case for intraoperative ultrasound and basically demonstrating that you could see it, and then characterizing and grading the type, severity, and outcome in these patients after suffering an acute cervical spinal cord injury. They had 30 patients, and these are the type of injury patterns that they saw after their initial injury. 16 were central cord, 8 were quad, 4 were an anterior cord syndrome, and 2 had only radiculopathy. And then the types of surgeries they underwent for treatment of their neurologic deficit and injury. 25 had a laminectomy for decompression, and 5 had a corpectomy. So, and then the intraoperative ultrasound, they posited that the regions of altered echogenicity would correlate to that injury in both the sagittal, and the way they defined the axial cuts was transverse. That seems to be another way of describing that in the literature, the terminology basically for those types of orientations. And then they were able to look at the injury volume relatively to the size of the diameter of the cord, and they provided a nice, useful grading scale for. It's very simplistic to think about for the amount of volume that it's taking up. So grade 0 obviously is no echogenicity. Grade 1 was a focal injury with increased echogenicity that you can see on the ultrasound. That's less than a half of the overall cord diameter. 2 was this focal increased echogenicity between half and full diameter. 3 is involving the full diameter of the cord, and then 4 would be full diameter plus the formation of a sister syrinx in that area, which you can see also on the ultrasound. Notably, they did have 12 patients that underwent MRI to compare the image quality. And then they were able to somewhat correlate the intraoperative ultrasound imaging with that MRI. And they followed these patients again at their initial presentation and followed at various follow-up time points, which were somewhat variable for each of the patients, with the longest follow-up time point being at about 36 months, so 3 years out. I believe that was for 21 of the 30 patients, to assess their neurologic outcome as they went along. So I thought this would be nice to show some of the comparison examples that they provided in their paper. This is what they would categorize as a grade 4 lesion. So again, kind of the full diameter in theory of the cord, basically correlating to that area at 3-4, where you get that T2 hyperintensity that they can see, and they're pointing with those arrows to show that that's where the lesion would be on intraoperative ultrasound. And then here's a couple more nice pictures they have. Even for the 90s, they have some nice imaging where you can see again the 2 areas actually in this injury. In the second, I guess, comparison, where you have that area of increased echogenicity correlating to where you see that on the MRI. So again, they had 30 patients that they looked at, and they noted first when they were reviewing their results following these patients that the parenchymal spinal cord lesions that they saw at the level of fracture or stenosis were compatible with the initial neurologic deficits that they detected on intraoperative ultrasound in the patients presented with clinically in about really almost all of the patients. They really quoted about 29 of the patients with technically adequate studies. I think there was one patient they said they couldn't actually see it based on the fact that the ultrasound wasn't giving them adequate data. They did also note, which I thought was interesting, was that their grading that they noted, their injury grading scale, was correlative with the initial Asian motor score that they saw on initial presentation, which would indicate that the amount of echogenicity or the amount of lesion volume is related to their initial traumatic clinical motor deficit that they saw in Asian motor score. They then demonstrated that both the intraoperative ultrasound injury grade and the initial ASIA score were correlated with some follow-up ASIA scores. However, they did not improve their predictive ability to say what the follow-up ASIA motor score would be. So again, interpreting this as the initial grade, initial ASIA motor score were similar in comparison with the overall extent of the initial traumatic spinal cord injury, but really provides, again, no implication or inference on how they're going to do neurologically as we follow them. But again, interesting that you can see that and correlate it to an image and say, oh, this kind of intuitively makes sense. Notably, again, back to those 12 patients that had comparative MRI, they were able to show correlatively that their ultrasound matched with where the imaging or where the injury was on the MRI. So just kind of a little side note, again, kind of makes intuitive sense. Again, so, fairly simple study, but again, demonstrating the use case well, in that they highlight that it's a highly sensitive technique to show and confirm really the presence or absence of spinal cord injury following trauma, and that which the extent and character you can qualify and provide some quantitative accuracy using this grading scale. Again, this does not allow you to predict their recovery or outcome. It just gives you a point in time after their initial injury. So reviewing this paper, it's a nice paper. They had perspective and interval follow-up in these patients, and again demonstrates the utility of this imaging in trauma, which I think is one of the best applications for this technique. Again, they only had 30 patients, but that's pretty good. There's always a potential to have more patients, and they provide a nice useful grading scale, which is very kind of intuitive and simple to use.
Quick question. In the literature, I think it's been stated that the presence of an intramural hematoma is associated with a poor prognosis. Did any of the patients in this study have one that they were able to identify either with the ultrasound or the MRI?
That's a good question. They didn't specifically mention hematoma. They were really just talking about like echogenicity and hyper intensity that they saw on a few that had MRI. But they didn't specifically talk about or specifically mention hematoma. At least from what I remember, yeah.
The one comment that I'll make is I think that if you see a highly echogenic lesion in a patient who has had a spinal cord injury, you know, a lot of times it is probably a hematoma, and
Yeah.
I mean, it is pretty easy to see on ultrasound.
Yeah, actually, if you go back a couple slides, it's probably that first picture may be a hematoma, the full extent and diameter of the cord, and then the next one too, I guess. The next slide where you see those like kind of areas where it's lighting up, that arrow at the bottom would be concerning, I think, but.
All right, we can move on to Tim. I think Tim was going to share his screen.
Everyone see this okay? Yeah, I did want to just put mention this one paper. We have part of this journal club, like Josh said, is going back in time. Did want to take a moment here just to acknowledge some of the pioneers of the technique. This story of intraoperative ultrasound, it's fascinating because, you know, it's really been around for at least 40 years. And yet we're even now continuing to find new applications for it. And yet I think we'll see from this article that a lot of the story has really been there from the beginning. So this is an article, Doctors Rubin and Dorman, University of Chicago. I just want to mention the University of Miami was also very instrumental doing some of the earlier studies of intraoperative ultrasound in this setting. So what, you know, these authors, they really described, you know, among the first described the invaluable surgical role of this technique: localization of lesions, ascertainment of lesion resection, verification of decompression in a variety of settings, searing, cysts, shunt placement, tumor resection, discs, stenosis. Importantly, they were, you know, when this technology first came out, was even really before the prior to the routine use of MRI. In this article, they do make comparison to contrast, enhanced CT and myelography. This specific article looked at 36 operations, a variety of indications. But above all, you know, it's clear that the most important point is that this allows neurosurgeons, orthopedic surgeons also, of course, to evaluate the procedure during the operation itself. One point here that is interesting, you know, we've been talking about cord motion. These authors were really the first to correlate spinal cord motion with cardiac rate. But what's interesting, they made an interesting observation, and they really provided a somewhat provocative hypothesis, but which I think even today is not really fully flushed out or put to rest. And that's that, you know, while one might expect there to be a linear relationship between increased cord motion or pulsatility and adequacy of decompression, Rubin and Dorman, they really argued that the relationship is the inverse. And they judged that the primary driver of spinal cord motion is the anterior spinal artery, in that they felt that the more that the artery is compressed, the greater the motion of the cord. So they actually felt that the more motion that the cord would show is that could actually be an indication somewhere of compression. But that's just something to keep in mind. Just moving on, you know, this is an article we actually put out. Really trying to apply this to specifically to medical subtraction osteotomy. So in our article, we certainly well known it can improve sagittal alignment, but there's certainly significant risk, neural element risk of injury. Typically, and for many years, we've certainly used SSEP's motors to help monitor the critical portions of the operation. And in this paper, we really just looked at 3 cases of thoracic PSO, focus on feasibility findings and utility. What we found is that in each case was able to visualize spinal cord morphology at each phase before and after closure of the PSO wedge. And in certain instances, it actually really influenced our surgical decision making, specifically with regard to the final amount of sagittal plane correction. In addition, it was really useful for confirming ventral decompression of disc osteophyte complex. Of course, when you make your wedge osteotomy, it doesn't completely guarantee that there isn't still some disc osteophyte or some other kind of debris ventral to the cord that when you start the closure that couldn't indent the cord ventrally. So that's one of really stage 1 of how this was helpful, but also really after the reduction, and I'll show this on the next slide, almost invariably you're going to see some kinking of the fecal sac. But unless you use the ultrasound, there really is likely to be, unless you can see through the dura, going to be some uncertainty about the underlying status of the cord. So we concluded reliable modality fits well into the technical sequence of PSO, minimal amount of additional operative time, and few limitations. So this is just one figure here. You can see with the red arrow, this is a longitudinal or sagittal cut. You can see pointing to a disc osteophyte complex, some remnant of which has been pushed ventrally, as well as that kinking of the dorsal fecal sac with the blue arrow that I mentioned. And then with the ultrasound, you can see the cord is nice and free with good integrity. This is just another slide here. This is before and then after closure of the wedge defect. You can see here, just pointing out that kinking of the dura, which we again almost invariably see, and then again finally, just another slide here, really beautiful image. You can see beneath this change in the appearance of the dorsal dura, you can see that the cord appearance is good. So this was helpful, particularly in one case. After we had made closure of the PSO wedge, we did actually have a change in SSEPs. First step, of course, we brought in the ultrasound. We took a look. Cord looked just something like over there in Figure C, and we decided to leave the amount of correction, and that turned out to be the correct decision. It wasn't long after that we had complete return of SSEPs, as well as having had motors. So, just one last thing, one last article I do want to mention. This is my good friend of mine, Brian Huang, just graduated from Johns Hopkins, real superstar neurosurgeon. And in this article, which really got a lot of attention, really is looking at moving beyond the use of ultrasound and spinal cord injury in particular, kind of just beyond the role of evaluating anatomy. There's a very nice figure here. They went back, narrowed it down, looked at 32 studies and divided the categories up into those, really providing novel diagnostic techniques, as well as low intensity and high intensity focused ultrasound and the potential role that may have really in spinal cord injury in particular. And the papers, it's a very brief paper, but it's very nicely organized. And the three, really trying to see what this technology can do for better characterizing the injury beyond, again, visualization of anatomy, getting into some functional imaging. What can it offer as far as tissue regeneration, and then again also as far as functional restoration. So some of the key points, that have really been yet to be fully explored, that ultrasound might offer: real-time monitoring of blood flow. Perfusion is certainly one, using Doppler technology. They do point out, some of the challenges with this, and some room for technological innovation is historically, and with the technology we currently have, a lot of it's really geared toward larger vessels, faster flowing blood. So we really need something that can look at really better at the smaller vessel size of the spinal cord, for instance. Other areas to be requiring research, biomarkers of injury, inflammation. There's some preclinical studies looking at targeted microbubbles, specifically targeted to markers of inflammation, and what this may tell us, about prognosis. There's certainly room, ultrasound, really getting into the focused ultrasound portion of things. There may be a role for it in the delivery of pharmaceuticals, opening up the blood-brain barrier as it pertains to the spinal cord. Certainly, research at our own institution so far has been focused on the brain, neuromodulation, neuroprotection, again, using low-intensity focused ultrasound, for instance, recruitment of BDNF. And then also, finally, may have a role as far as lesioning for pain, some possible targets there, and using high-intensity focused ultrasound. Again, just to summarize areas where there may be potential applications. And then, just importantly here, this slide, you can see, as we've divided into the 4 categories, most of the current research really is in just the preclinical stage at this point. So I personally, I thought this was a great article. There's a lot of areas of excitement, and it's very curious to see where this goes over the next decade.
Can I ask you a question?
Yes, please.
So thanks. Yeah, so this is a nice little survey thing. I love that diagram. I'm going to download that article. Gav next to me is very interested in ultrasound. Also, he showed it the other day in a case. Very helpful. So my question is the following. In your article on world neurosurgery, how often, in that very wide decompression, did the use of an ultrasound actually change your management? I don't know how large the case series was. Someone must have missed that, but how often did that lead to a therapeutic change in treatment plan?
Sure, that's a great question, and I really think that's the most important part of this. It hasn't always changed it. This was a very very small series of 3. I think it was really in this one case in particular where it really changed management. Where, again, we're using, in addition to ultrasound, we're using neuromonitoring, and that's what we've largely used by itself for many years. But in this one case, after closure of the wedge, we did have a change. We did have a brief change in SSEP in one of the lower extremities. Now, I think if we hadn't used the ultrasound, I think our first instinct is to remove or relieve some of the correction. And to wait and see. But what that change in neuromonitoring did, it prompted us to reevaluate with ultrasound. And we can really see that the morphology of the cord the integrity was outstanding. There was nothing really untoward from the maneuver that had happened to the spinal cord itself. So what that prompted us to do was to leave, the amount of correction that we'd had with that change. And again, later in the case, that was proven to be the correct decision. By the end, all neuromonitoring modalities were at their baseline. So in that instance in particular, it really helped our decision making.
So I also asked for clarification of one statement you made before that I may or may not have understood correctly, and that is cord pulsation. So when I operate on a cord at risk, I really look at pulsations as a good sign. Let's say I've had neuromonitoring changes, and the first thing I want to do after map adjustments and whatever further decompression, I want to see cord pulsations. Now, please go back to your sentence again, and I think it's relation to that 85 paper by Rubin et al. Is cord pulsation a good thing then? Does it show truly anterior spinal artery perfusion? Is that a CSF pulsation? Or is it irrelevant? Or is it a bad sign?
Yeah, no, I put this in here just because it is, it is a bit of a controversy. What exactly do cord pulsations mean? And as are they, again, in this article, as you say, are they a bad thing? And in a way, this article is arguing that they are. I personally, I don't necessarily agree with that. I've certainly seen cases that are just very, very nicely, widely decompressed, and you can see cord pulsatility. So I don't know. It would be certainly be, something that I think would require further study. But I did throw this out here. It was, certainly one part of all this that there historically has been some controversy with.
And our good friend Dr. Maximino Tellez-Guts again identifies how nice it is to have two modalities, ultrasound and neurophysiologic monitoring. In terms of sensitivity and specificity, where would you place ultrasound versus intraoperative monitoring?
That's a very tough question to answer. I don't think we quite know just yet. I think there's a very nice complementary role for both, and I think of ultrasound really as, we do it anyway, but I think, it's really a check on if there is a neuromonitoring change. I think that's something that would have to study much more closely, but that's a very interesting question. I think as of now, I don't think would want to dispense with either.
Yeah, I'll add to that too. I think that both are important, because neuromonitoring, tells you more than just what's going on at the exact area where you're doing the surgery, which is really all ultrasound can see. It can't tell you what's going on elsewhere. So, neuromonitoring can also detect issues with patient positioning, et cetera. The other thing that neuromonitoring is, if you stretch a nerve root, you're not going to see that on an ultrasound. Or if you slip and accidentally, hit the spinal cord or something and then get a neuromonitoring change, the ultrasound is still going to, not show anything. So it's an adjunct, it's an additional thing. And one thing that I'll also mention, based on Jens's question about whether or not it changes our decision making, in these cases, well, in this series, where there were the 3 cases, it helps, if you do have a kink in the dura, it's very easy to look with the ultrasound and make sure that the spinal cord looks good. I would say that the biggest way that it changes my decision making is anytime there is pathology that is ventral to the thecal sac, because my approach for, thoracic disease that's in front of the spinal cord is to take a, posterior lateral approach where I'm doing a transpedicular or a costo in order to reach that pathology rather than, going transthoracic or anterior, is that it allows me to see what's there. And very often, I will think that I have removed, enough of the ventral tumor or enough of the disc that's caused the disc herniation. And I check with the ultrasound, and there's still, even though I've run my Woodson, underneath the thecal sac, there's still some area of compression on the ultrasound that I need to work a little bit harder to get. And, if I didn't have the ultrasound, and who knows, maybe that's not even clinically significant to get that little bit if you removed the majority of it, but it at least, gives me reassurance that I've done my job or that I need to go back and take a little bit more.
One big question for me is, this is hot topic in acute spinal cord injury, obviously, of intentional durotomy and CSF release to maximize cord perfusion. Do we have, and is a leading institution, is a leading expert like you able to see or estimate cord perfusion better intraoperative with ultrasound, using to kind of get a better gestalt of how our cord perfusion is looking? Because again, for me, this is still one of those things in a large bad cord injury. Do we do the durotomy? Do we jump to that measure, or do we hope for the best? And could ultrasound perhaps guide us? And if so, what kind of a frequency, what kind of modality would we use to determine that?
Yeah, I mean, it can certainly be useful, and we've certainly seen that as an example, because we as an institution, do frequently say there's a patient who has a spinal cord injury and we treat it anteriorly initially, but they have a lot of cord swelling, on their MRI. We'll frequently take them and turn them over posteriorly and then do a posterior decompression and potential fusion as well. And we've certainly seen cases where you do that, you do the laminectomy, and then you get the ultrasound out and you look at the spinal cord, and the spinal cord is almost filling the entire thecal sac. And we've definitely chosen in some of those patients to perform expansile duroplasties on those. So I think the ultrasound is very useful in that regard.
Yeah, that's one of the that's a very hot topic. What are going to be the indications exactly for expansile duroplasty? And we certainly feel ultrasound can have a role in deciding when that's necessary. I think the exact parameters you see, what precisely those are beyond the obvious cord swelling, those aren't exactly established yet.
Yeah, currently it's really, again, qualitative. It's this idea of the sausage cord phenomenon, constriction of the dura, which you can see under ultrasound at least. So at least it's a very nice modality for that.
All right. Any other papers, or where do you want to go from here? Do you want to show your case, Ken?
Yeah, if we have a couple minutes. So this is just a case from about a month ago. Let me share my screen again. So this was the case. The initial case itself is not that important. It was a guy who had back pain, leg pain, neurogenic claudication, and foot drop, and he had pretty severe multi-level lumbar stenosis. Also had some fairly significant foraminal stenosis at L5S1. So we did a L2-S1 decompression and fusion, and on post-op day 2, he developed some very severe bilateral leg pain, and his legs were a little bit weaker. So we sent him for an MRI scan, and he had a couple things. Number one, he had, sort of this epidural collection, which when we took him back to the operating room, it turned out to be not really much. It turned out to be just very swollen muscle. And a little bit of a seroma. But what was more critical was up above, he had this sort of arachnoid cyst or subdural collection or something that had developed within the thecal sac above the area where we operated, because this is at the T12L1 disc. And you can see on the axial, again, the spinal cord is being compressed and deviated ventrally. So, the question is, well, what the heck is going on here? We didn't operate there, and the bigger question is, well, what do you do for this patient? Do you have to take him back to the operating room and then, perform laminectomies up here and then open up the dura and see what's going on? And so we did take him back to the operating room, and we basically opened him up, and then down here again we didn't really find a hematoma. We just found very swollen muscle, along with a little bit of a seroma that was causing some compression of the thecal sac. But then, and then we did do a laminectomy where we removed more of L1 and T12. And then we looked with the ultrasound. And when we looked with the ultrasound, this left image is sort of a sagittal image right at the conus, which is where that cyst, or we didn't know what it was, the cyst or that hyperintense, fluid signal was pushing on the cord, and it was displacing it ventrally. And you could see that here that it was fine. Now that wasn't there, the cauda, the conus and the cauda equina was free floating. And then but you can see some areas of arachnoid there, but they're not compressive. And then the image on the right is further down, in sort of the middle of the cauda equina. And this is an axial image showing the nerve roots. But then you can see that there's these sort of arachnoid webs. And so we didn't do anything. We didn't open up the dura. Everything looked okay now that it was decompressed, and we actually got an MRI the day after, and it's fine now. There's no cyst lesion up here. The thecal sac is completely open, and the patient, his pain went completely away, and his strength was back to normal. So my theory is that because he had such severe lumbar stenosis for a prolonged period of time, he developed some arachnoid adhesions intradurally. And then when we decompressed him, those arachnoid adhesions filled with CSF. And then when he had residual when he had the compression from the swollen muscle and seroma, it pushed that CSF back up into his thoracolumbar junction region and caused the spinal cord compression. And then when we relieve that compression, then the CSF normalized again. But if we didn't have the ultrasound for this case, I don't think I would have had any other option other than to open the dura, around the conus, just to check and make sure that it's not being compressed, or to see what's going on inside the thecal sac. So, I'm glad that we had the ultrasound for this case. And I think that that's a good recent case that I had that sort of shows its utility in sort of an unconventional way.
The dynamic of intradural hydrodynamics and space occupying lesions is certainly fascinating. I really enjoyed your presentations, and again, a case that we recently did with Yev Favorit's help, who's from UCLA and who's quite experienced with ultrasound, was really evocative. In closing up, maybe I'll ask Dr. Lieberman to unmute himself. He does a lot of very complex deformity surgeries, and I'm just going to ask him about his experience and if this lecture will change him towards adding ultrasound to his intraoperative armamentarium.
Jens, can I just butt in before Izzy gives his, before Izzy says anything? I just want to
always one-upping me, Rick.
No, I have a quick question. Ken, what is the ideal size you think to use it in the lumbar spine if you could design yours? How many millimeter in diameter?
I mean, I think that if you had one that was about centimeter in diameter, that would be an ideal probe.
Even for microdiscectomy?
Oh, for microdiscectomy. Sorry, you were breaking up a little bit, so I didn't hear. I would say, it would probably have to be like 5 millimeters, 5 or 6 millimeters, which maybe that transsphenoidal pituitary probe is good enough, but we haven't gotten our hands on it yet.
Okay, thank you. All right, Izzy, sorry.
No worries. Thank you, everyone. Jens, thanks for putting me on the spot yet again. This is fascinating stuff. We're in a very privileged position right now in that all this technology is on the shelf and we just have to figure out how to use it. What I think was really fascinating and highlighted with this series of talks is we have so much to learn. We just don't understand the CSF hydrodynamics, the pulsations of the cord, the function or the pathology associated with some of these arachnoid webs. How many times have we had cases where we've just been absolutely mind-boggled and couldn't figure it out? And over time, things tend to settle. But maybe with this technology, we're going to be a lot more specific to some of these very sensitive issues. So everybody have a great July 4th weekend. Stay safe. Not too many hot dogs and sauerkraut and lots of fireworks.
All right, take care, everybody. Thank you.
Goodbye.
Thank you, Maryland.
Happy
Fourth.
Thanks a lot for having us. It was a lot of
Happy
fun.
4th.
Oh, dude, no fireworks.
All right. Well, welcome to 2 new colleagues.
Thank you.
Thank you. So just tell us who you are.